Tony Smith. I'm a director of Greener Practice, and we're very, very privileged to have Anna Kirby with us today to talk about stopping frailty before it starts, which I'm really excited about this talk. I've been excited about it for a long time. So I was just having a quick chat with Anna. Anna's a GP in Nottinghamshire and has started the Later Life GP as a sort of spin-off because there was nobody available to fund the work, which is, you know, speaks for itself, doesn't it? You know, this work so desperately needs to be done, but you know, it's a bit of an indictment of the system, really, that Anna's had to do this off her own back. But I was just saying to Anna, I think I want to clone her because the work she's doing sounds really incredible. So without further ado, I'm going to hand over to Anna. So we're going to have a bit of, Anna's going to do a presentation for us, then we'll have time for some questions. I'm going to show you a little bit about the Greener Practice platform and also to ask for your feedback for Anna's talk, and then we'll have a session of questions and answers. So over to you, Anna. Thank you so much for being with us today.
Hello, thank you for having me. So yeah, I've just been introduced beautifully by Honey. So yes, I'm a GP. I work in Nottinghamshire in a normal GP practice, but I also do some work around frailty prevention because it's something that gets me on my soapbox and talking an awful lot. And also work for our local ICB, working within the framework of frailty and looking particularly at polypharmacy and deprescribing. So that's who I am. I'm really hoping that my presentation is going to behave now and share. So let's have a little look and see if I can make this work. Can you see anything as yet?
Oops. Not yet.
Let me try again.
You're just making me feel better.
Wonderful, and it's wonderful and it works, isn't it? But
yes, I'm sure I'm going to have the same problems in a few minutes.
It looks a little bit more promising my end.
Yes, you see we can see it now.
Fabulous. All right, so just gonna get rid of some pop-ups. So the talk today is around a program that I set up back in 2023, something called Fitter Tomorrow, and these are the guys that made it possible. Really, these are my willing victims in the first two cohorts of my scheme that I ran. So as I said, I'm Dr Anna Kirby. I'm a dual trained GP, but I'm also a physiotherapist, and I haven't practiced as a physio for a few years now, but that was my background before I came into medicine. And I funded medical school by working as a rehab physiotherapist in the private sector, specialising in frailty. Now, where I work, there's a very mixed population. We've got quite a heavy rural population with lots of older people, but our practice boundaries go right the way up to the almost the inner city. So I have a real mixture of patients. Most of the ones I spend my time working with are from our branch surgery, which is in a more rural setting, but has one of the oldest populations in the county. So day to day, I spend much more time seeing people over the age of 80 than I do seeing people under the age of 10. So that's how I sort of spend my days. Now, one thing that always is a bugbear for me is we spend so much time trying to fix things, and firefighting, and much of the NHS feels like it has been set up to firefight and deal with the emergencies, and with such a finite amount of money, that's where it's had to go for the last few decades. But one of the things that really winds me up is that actually a lot of this stuff we could deal with, and we could deal with much more cheaply if we actually put that money into prevention earlier on and stop these problems from happening. So that's where this came from, essentially, in terms of how we go forward. I wanted to do something that fought frailty and that was non-medicalized in a sense, and actually saved my patients from becoming to a place where they were unwell, and tried to keep them well instead. And I had a brilliant opportunity through Nottingham's LMC, who are very active, and they run a thing called the Phoenix programme, which allowed me to do a year-long clinical fellowship, funded for one session a week through them. And during that time, I could work with my PCN to run a project that met the needs of our population. So that's how this scheme that's Fitter Tomorrow came about. So I'm sure you guys are very well versed in frailty and what it is and the problems that it brings with it. But when I personally think about frailty, when I explain it to my patients, I think about frailty as being simply a state of increased vulnerability where the body has a harder time bouncing back from even minor illnesses or injuries. So in its sense, it's something that's quite easy to understand. But really, the problems then come with the knock-on effects and to health, to function, to independence, of just not quite getting over these minor kicks. And then as things progress, you sort of get to a place where confidence is lost. Perhaps you're more socially isolated, you're not living the normal life. Finances can be compromised. And not just your life expectancy shrinks, but also your fullness of life shrinks away. So life itself begins to sort of shrink. Frailty is a major problem. So I think the British Geriatric Society frailty briefing from last year stated that 10% of people living in the community over the age of 65 are living with frailty. And when we think about the older population living in different settings or in hospital, or those over the age of 85, wherever they're living, the proportion raises quite significantly. And they were suggesting that the rate can be certainly sort of well over 50% in those groups of people. And then there's also a big study back in 2022 looking at a retrospective cohort study looking at electronic data from general practice surgeries from over 419 surgeries looking at 2.1 million patients. And they suggested that the proportion of people over the age of 65 living with some degree of frailty was 43%. So that's an awful lot of people. And even conservative estimates from the BGS suggest that the cost of frailty to the UK health system each year is 5.8 billion. That's an awful lot of money. And when we think going forward, it becomes a little bit more depressing. So lifespan in the UK continues to increase, which is clearly a good thing. But the health span, so the amount of time that someone is staying well during their lifetime, sadly, is not keeping up with that. And when we look at predicted populations and the changes are set to happen as we go through the next 20 years, the number of people over 85 is set to double by 2045. And if health span is not increasing with that, that's a lot of people who are not living the lives that they should be living and that they hope to be living. And that's an awful lot of strain on us as health professionals and the NHS trying to fix things. So when I then come back and I think about, how do we do something about this? I mean, I will be 65 in 2045, hopefully. Yeah, I hope to spend my retirement embracing life and spending time with my friends, my families, seeing the world, doing all the things that are important to me. I don't want to be spiraling. So I intend on keeping myself in a place where I'm as fit as I can be. So it's then going back, and none of this is rocket science. If we can keep people healthy, if we can intervene and prevent heart disease, strokes, cancer, dementia, all the things that particularly lifestyle interventions that aren't medicalized can really make significant gains with, then actually we could be in a place where we could protect our patients. So that's really where my soapbox came into play, and the things that I was really pushing for my patients. And I mean, day to day, I bang on at my poor old patients about exercise and muscle maintenance and avoiding sarcopenia, so where the muscles become weaker and we lose that bulk and that effectiveness of those muscles. And all those little bits that can be done around the edges that do not need a doctor to keep people strong, to keep people well. Yeah, to try and keep people in a place where frailty is not on their radar even. And this is the immediate thing for me. This is my mum and my dad. My dad is 79 now, my mum is 75, and this is them at the top of a mountain. And I think that's important to say that actually, by looking after yourself and making those sort of life choices and being informed about which bits to do and which bits that could perhaps just slide a little bit more maybe, and where to put our priorities, it's entirely achievable. And of course, there's a degree of luck involved, but yeah, there are things we can do. So to persuade the people behind me to back a project, of course, I had to look and had to be nicer than blue sky thinking. And there was a Health Improvement Scotland document back from 2019, which strongly stated that if frailty is identified and targeted with evidence-based interventions, both quality of life and well-being can be positively influenced. So this is coming from UK, governments in terms of backing this is where we should be putting our money. And in doing so, from their perspective, of course, their population are healthier. But we're also in a place where we're using less expensive unscheduled care and therefore sort of preventing patients from entering a crisis, which is good for everyone, patients and for us as a service that are running. So how do we do that, I guess? And as I've said before, I bang on at my patients left, right and centre. And those evidence-based interventions that they talked about in the document aren't rocket science. So strength and exercise. I think this is becoming a lot more out there, isn't it? I think there's a lot of talk now about muscle training and strengthening, particularly maybe in the female population in the menopause thing that's becoming quite current at the moment and promoting sort of strengthening exercise. Also looking at balance and coordination. So the things that go together, what's going to stop me from falling? What is going to keep me mobile? What's going to keep me functioning? All those things day to day that we do without thinking right now. But as we get older, we hit our 70s and our 80s, perhaps our muscles are starting to have those natural age changes. And we know that from age 40 onwards, our muscles start to sort of decline in muscle bulk. And by the time you hit 80, you may have lost sort of 40% of that muscle strength you had in your 20s if you don't do anything to prevent that. But strengthening exercise can do a lot for that. Balance and exercise work, balance and coordination, work, we know that that is successful in helping people not fall. So making sure that started in an early stage too. And alongside that, the health protection messaging that I'm sure we all tell our patients day in, day out. So the smoking cessation advice, alcohol advice, healthy diet and sort of nutrition, all those things that we tell our patients when we get the opportunity. But actually, when patients are well, that's when that message needs to really get through to them so that we're not firefighting and we're not trying to play catch up when damage is already done. Social isolation. So social isolation is something that's quite hard to influence as a doctor, and it's not something that we necessarily think to ask our patients day to day. But if you're seeing a patient and your radar's out there that maybe this is someone that is lonely, we know that loneliness is prognostically really poor, and particularly so for men. So we know that men that live alone have an increased chance of dying compared to married men who are cohabiting, men who aren't living by themselves. Interestingly, that's not the same for women. So I don't know what we're doing right as women in terms of protecting ourselves, but yeah, particularly having on our radar when we're talking about our male patients. Optimizing chronic disease management. Well, this is where it gets more medical, isn't it? And it's dragging our patients in for their annual reviews and making sure that we're really paying attention if things aren't quite going the way that that we'd like them to be, but searching for those illnesses as well in the first place. So encouraging those health checks so that we can help do something about it before it becomes a major problem. And again, something that's also very difficult to influence as a doctor, particularly thinking about deprivation, social inequality. And so maybe even if we can't really influence that directly ourselves, having it on our radar and making sure that if we're suspecting that someone is at a place where their opportunities aren't as they should be, looking at how we address that from our surgeries, looking at maybe social prescribing referrals and making sure that everything that can be done is being done. And for those people working at a more strategic level, making sure that we are doing everything in our power to address that social inequalities and minimizing the effects that it can have therefore on health. So that's the how in terms of what I needed to bring into my practice. So then the next question was, well, how do I actually turn that into a scheme and something that works? Now, I have the lucky situation of having a wonderful other half who is a consultant anaesthetist, and he has colleagues who are running a very successful prehab service across their local hospital. So I found out about this prehab service, which is using all of those things in patients who've been recently diagnosed with cancer to get them as fit as they can be before their surgery, to help get them safely through the operation and out the other side, and to diminish the deconditioning that goes with a long hospital stay, and to get them on the track to recovery as quickly as possible. So I was very lucky to be able to steal some of their ideas and some of their systems, and then get in contact with some of their providers too, their exercise providers, to work out how we move that forward locally in a way that was even more preventative, because sadly, by the time my patients, or the patients that hit that service, are exposed to that wonderful scheme, they are already in a place where they are living with an illness that we would have preferred them to have not had in the first place. So with this idea in mind of exactly what I wanted to do and lots of enthusiasm, I then had to sell it to my PCN to say, please fund this project that I'd like to run. And that's when I really needed to find out how much influence this could make for a budget perspective. Now, back in 2017 and 2018, there was a data set gathered that could predict what happened if we addressed frailty in a more proactive way. And they discovered that if 10% of severely frail people stayed moderately frail, the saving in Kent alone over a 10-month period would be over £1 million, £1.6 million. And that was once they'd corrected for age, gender, deprivation, all of those things that might skew the sort of the predictions. So that was if we're keeping people who are frail already, moderately frail, and not letting them get worse. But again, for me, that was still missing the boat. These people are already suffering. So asking that next question, what happens if 10% of mildly frail people remained fit? What would happen then? And I've given the game away and clicked my button too aggressively, and you can see the answer there. But £9 million worth of saving if we could just keep 10% of the people who are mildly frail in a fitter state and not let them drift into frailty. And I'm sure we can think of an awful lot of things to do with that money, and things that would make big differences both to the next generations coming through and to the ones that are already sort of suffering and needing the help right away to sort of treat medical problems. And of course, some of that comes from the fact that there are a lot more people who are living with mild frailty as opposed to those living with severe frailty. But just 10%, that's all we need to access to really make a meaningful difference. And you know what, if we could get more than 10%, that money's just going to go up and up and up. And so there should be some benefit from a strategic level for the NHS itself. But as me, as a human and as a person, as looking after people that I care about, that I've cared for in this surgery for the last 11 years of working here, actually, if I can keep those people living their lives, living those full lives, well, I can go home feeling proud of what I've done, and I can feel that I'm contributing to my community and not just being a doctor. So I think that that's really, where I come from on this front. So thankfully, the PCN directors were on board, and they allowed me to steal their R's staff, so the team that we already had there, and pinch them for a few hours a week. And they agreed to cover the cost of some room hire and to work with me, and to bring this into fruition and see what difference we can make to our local patients. And I'm probably doing myself a better job, but actually, we didn't need doctors running this. We needed those other health professionals. We need those other human beings that were passionate and cared as well. And so that's what we did. So I built a team with myself overseeing things, with a care coordinator, and also I pinched our dietitian from the PCN, and we had a fabulous health and wellbeing coach who was just as passionate as I was, who was on board and led most of the day-to-day work that we were doing. And we also managed to approach ABL, which is an exercise provider, amongst other things, that provide lots of lifestyle interventions for Nottinghamshire, and got them on board. And they were able to set things up so that we could run our scheme without having to pay for the personal trainer, using streams of existing Public Health England money for prevention. So that was fabulous. And we brought in the local leisure services as well to run this within our community, in a place where people could get to it. They weren't having to drive for miles, and in venues that they were familiar with, to bring it on its doorstep, essentially. So I set Hera the challenge to find some victims for me. And my experience had been that through the EFI, of just seeing the things that we got coded in our notes, that actually within our population, it appeared to overestimate. And I'm sure that is a failing of our coding systems and what we're putting in the notes, rather than the EFI itself. But my perception had been that patients that were coded as being mildly frail actually weren't. They were pre-frailty patients. So we sent out mass text messages to everybody over the age of 65 who had an EFI coded on our system. And Hera had done some work a few months before, going through all of those patients' notes and calculating an individual score. So we had a lot of patients to pick on. We sent them all a text message and invited them to get involved. Those that replied to the text message had a conversation with Hera, and we used the clinical frailty score tree to sort of predict and work out who possibly had a CFS score of 3 or 4. So we're actually in a place where they were managing well, or living with very mild frailty, or as our system one says, sort of being the old classification of being vulnerable. Now, my reason for picking that particular group was that when they were fit and they were active, there perhaps wasn't a motivation at that moment in time to change. And I was trying to be a little bit manipulative and pry on people who were maybe at a place where they were starting to feel that vulnerability, that were thinking, actually, maybe this is the time for me to do something, to commit to something, to bring about change that can really be useful. So that's the reason I went for that group of people and how we access them. Whoops, skipped a bit too far ahead. So we then collated quite a long list, actually. We had lots of people who wanted to get involved with this, and we brought them all in for an appointment with our health and wellbeing coach, Joe, who collected some data, and we weren't quite really sure what to look at. So we looked at the things that the prehab team were looking at. We looked at the information that our partners in this, so the ABL, required for their public health information stuff. And we looked at the things that we felt would matter to the patients as well. So we looked at blood pressure. We accepted anybody who had a blood pressure under 180/100 as a starting place. But of course, we pulled them in, and we signposted, and we got them in either with one of our nursing team or with a GP to try and get that optimized as well. So all these little bits, there were opportunities for that chronic disease management and sort of moving that forward to that sort of optimization. We looked at the heart rate and made sure that everybody was in a funny rhythm that we needed to know about. So we looked at oxygen levels too, and to make sure that we felt that they were going to be safe to exercise. We assessed BMI. There wasn't a cut-off on paper, although we did take the opportunity to signpost people perhaps to other services alongside what we were doing if they had a particularly high BMI. And we had the luxury of being able to fit them in with our dietitian too, whether they had a high BMI and needed perhaps that starting place to make changes that they could bring into place straight away. And for those who were maybe underweight, we then allowed our dietitian to look at them too, and to do a score and try and look and work out what was going on. We needed to quantify how much exercise people were doing. And for the ABL scheme and the Public Health England funding, we needed to be doing attacking people who were sedentary, essentially. They had to be doing less than 30 minutes of exercise every week to be able to meet that funding stream. So we did have a few people who were keen and who were too active to be able to meet our scheme. But thankfully, we could work with them on an individual basis. And Joe, our health and wellbeing coach, met with them and helped them formulate goals and helped take them forward to still get the benefits, even if they couldn't join onto the scheme itself. and we looked around mental health. Now, we couldn't really find a perfect score to use for this. The prehab team were using PHQ-9 and anxiety scale, so we did take a bit of an assessment of that, really. But more than using those figures and those scores specifically, if it raised anything that made us worried at that initial assessment, that patient was offered an appointment with a GP to talk things forward, and then the opportunity to go on and work with our mental health practitioners within the service, within the system at that point in time too. So we're looking holistically at these patients. And we looked at loneliness too. And again, with the score we chose was a campaign to end loneliness score, which just gave us, again, that little indication of people that maybe we needed to get in touch with our social prescribing team and to look, again, holistically at that patient. What could we do to help this patient in their life day to day, rather than simply pick them up for the scheme and then drop them again afterwards? And we looked at more practical health things that are being asked quite frequently. So we explored alcohol. We didn't require to send anyone across to alcohol services, but we had a scheme that we had a path we'd take if we had needed to, signposting to our local alcohol services, and our health and wellbeing coach could talk things through as well if it wasn't quite at that place, but they just needed a little bit of guidance. Looking at smoking status, and we did refer a few through to smoking cessation from this. And then we looked at what was our main objective test to see how much progress we were going to make in terms of the influence on this patient's strength, on their falls risk, and on their ability and the strength. So we looked at the sit to stand 60 text, which you may have come across, or it's the spin-off version that's the sit to stand 30. So that's how many times within 1 minute a person can sit to stand from a chair. And yeah, it's nothing more complicated than that, really. But it does, there's some data suggests that it reflects where that person is in terms of certainly falls risk. So the less they can do, the more likely they might be to fall, and someone that can whiz away and do 100 in a minute or whatever else is probably less likely to be toppling. So that goes hand in hand with that whole idea of what that patient's abilities are and who we might be slightly more worried about from a frailty and a falls risk perspective, and all the things that go badly wrong when you start falling, and particularly when you start breaking things and your confidence goes as well. Of course, there's consent to be thought about. We make sure those tick boxes are done, not just for consent to join in, to understand what they were doing, what they were committing to, but also to share that information with our partners in ABL who are linked with the NHS, but of course outside of the PCN and the practice. And we did some personal goal setting. So this wasn't just for us, this was for the patients too. So Jay spent some time talking through and working out what was important to that patient in their life, how we could support them in taking that forward. And this is a structure that we roughly came up with. So hopefully it speaks itself a little bit. Joe assessed them. They were signposted or handheld into, and we booked appointments for them rather than just sending a text message saying, please, can you do this to the patient? So we made sure that they had that follow-up going on there. And then we booked them into the scheme itself. So they came along to do a combination of exercise and group education things. So we took cohorts on a rolling basis. So we took 6 people to start with, and then 3 weeks in, we added another 6 people into that list, so that every 3 weeks we swapped over, one group left and the other ones continued through. So they did 6 weeks of the intensive program with us. And by doing it that way, we also allowed them to be that peer support. So a lot of these people were sedentary, or all of them were sedentary, but a lot of them haven't exercised before. And it was quite a daunting thing to come into a leisure centre and made to exercise in front of people. So seeing the people that have been there for 3 weeks already and seeing that they could do things and having them reinforce that actually this is fine, we can do this. I couldn't do that at the start. Look at me now. Was a really motivational thing, and they looked after each other in a fantastic way. So we got them doing 12 sessions, so twice a week, 60-minute led PT session. And we worked them really, really hard. And I did this session. It made me sweat and it made my legs hurt for 2 days afterwards. But we deliberately programmed it so that we were working at a really intense level of exercise. And again, that's me being slightly manipulative. What I wanted to happen was these patients to be in a place that when we stepped away from them and we weren't there to crack the whip, that they would still be exercising at a moderate level. So with their 2 hours of exercise in the gym, and then we asked them to do 30 minutes at home as well. They were hitting that 150 minutes of advised exercise to get the main life benefits. So not only reversing frailty, but reducing their chances of dementia, of some cancers, of diabetes and hypertension from meeting that 150 minutes of moderate exercise a week. And we did all the exercises, the things that they could transfer across and do independently at home. So no big heavy equipment was needed. All of it could be done in just a room with a chair and with a hand weight. And they were given cards that they could then take home and work individually as that prompt to do things too. So that seemed to work really well. And then we also did education sessions. So Joe led a couple of sessions for us. The first was around that concept of lifespan versus health span, and understanding why we're doing this and why it's important. And then he did a touch base session as well halfway through, just to make sure we were as a group heading in the right direction, that any problems were sort of dealt with. And our wonderful dietitian provided a service as well there, with a small group setting. So providing that talk in the small cohorts of 6 patients, and covered so much within that session. And actually we could have really done with 2 of those sessions, but we only had it for 1. So it was a little bit of a whistle-stop tour, but we provided information to go along there too. We brought the local leisure centre in, and towards the end, to talk them through the services, to memberships and subsidised membership for some patients, to encourage them to go forward. And before every single session, there was a chance for them to get together, to have a chat, to build some friendships that would then hopefully carry forward once they graduated the scheme. And so we provided some cups of tea for them to be able to do that in an environment too. So outcomes, I'm talking too much and whizzing through, as I shall. Let's get to the bit that really matters. So outcomes then. So we repeated the same assessments that we did at the beginning, at the end of the programme. And we found that the sit to stand 60 improvement was plus 47% on average on where they started from. So that's a really big change in my eyes. That's and considering that the scheme only ran for 6 weeks, that's a big improvement, and one that they could actually objectively see themselves. And when we looked at the medium range, so they were it was not far off too, rather, when we sort of look at those different averages. We did find that one person hadn't improved. They'd gone down. In fact, they were still not doing awfully, but they'd gone back down again, and they stopped due to knee pain. And we did have some people that really, spectacularly improved. 167% was their biggest percentage improvement that we saw, from 9, which was really very low, to 24, which was still below where we'd like them to be, but was much better, clearly. And in terms of the real numbers of improvement, we were seeing that both the mean and the median increase was 10 extra sits to stand within that minute. So I think that I personally felt that we'd made a difference and brought things in a positive place. There's only one person, other than the person that went backwards, who didn't show an improvement, but they stayed static. And again, knee pain was the issue then. So that may be partly to do with the test that we'd chosen, and the strain going through a knee rather than other measurements. So if we ever tried to run this as a research project rather than just a useful project for our patients, then that's something that we'll perhaps look at. And this is a little bit more just on those outcomes. So, and the bit that for me makes the difference, when we're looking at both the initial ones, actually the people we brought through the door were, generally speaking, below where we might expect them to be for their age group. And maybe that reflects that actually there are lots of fitter people that didn't need our program, but these are people that maybe just felt that vulnerability. They were just starting to notice that they were not coping as well as they could be doing. So they were coming to us in a place below where we might expect them to be. But by the time they left, not only were they where they expected to be for their own age groups, on the whole, but the line at the bottom there. So this is what we'd expect people who were 60 to 64 to be doing. So all younger than the people that are in the room. And as a consequence of that, actually, we were potentially pushing them back where they were on that life journey, and improving things in a way that was that would hopefully be that goal of keeping them fit and fighting frailty, and in the fitter group of their age bracket. And the other things that we saw, well, there were lots of other things that were said and found, and we found that 20% of the people that came through lost 3 kilograms of weight during that 6-week program. So, and that's a sort of weight gain loss rather that we'd expect or would hope to with a healthy weight loss. So about £1 a week. We only had one that gained weight, although we did have a slight mix up whether some of the scales were to gain blame for that or not. But on general, people had lost some weight. So 58% had lost some amount of weight during that time frame. We didn't specifically look at this, but the general trend was that mental health appeared certainly not to have got worse through the programme, and actually they were scoring a little bit higher. Blood pressure and loneliness scores, well, they were variable, but we're looking at sort of one-off scores here rather than anything that really we could say that it was really objective and reliable. We were just looking at one-off consultation scores. And the loneliness, that also didn't improve in quite the way I'd hoped it had. I'm thinking about the reasons why with that. Well, actually, we were putting them in a group environment, we were introducing them to people, and then we were taking it away 8 weeks later. So it's that whole thing of a mixed message, and maybe that's something, if we ever do take this forward, that we can really explore and work out how we stop that from being a problem. So overall, when we follow people up down the line, so I managed to catch up with 14 people sort of 3 to 6 months down the line, and unfortunately my funding ended, and sadly both our dietitian and our health and wellbeing coach and our care coordinator sort of all left within that year. So I was left with a very deplete team and no one replacing, so we didn't get a chance to get in touch with everybody. But 79% of those people that I did get in touch with were still exercising at a level that was convincingly at the national guidance level 3 to 6 months later, and bearing in mind that those people were all sedentary at the start of the program, I took that as a win. And even if all the other people that I hadn't had a chance to catch up with hadn't made any improvements and they'd gone back to where they were, I was still making a difference of around 20% of people who had made positive lifestyle changes that they'd been able to maintain. And they might not do that forever, but even if we push back that onset of frailty by a year, 6 months, 2 years, hopefully a bit longer, but even if we nudge that back, that's still expanding that health span for these patients. That's reducing the time when we might expect them to need more GP intensive time, that they'll be able to maybe look after their grandchildren for longer, keep working for longer, contribute in life and have that fuller life for longer. So even if I've only changed that for 11 people, then I consider that a win. So the general themes of that feedback, well, 3 people reported that their energy and their mental health state was still better. This is 3 to 6 months down the line. 2 reported that they had improvements in their musculoskeletal pain. 5 said they felt better within themselves. 3 mentions that they felt inspired to continue from the classes that we'd run. And those classes I didn't mention, I should have done. So they were small group, but they were just for the people of their age group. We let them choose the music. It was very interactive. They worked together, and I did enjoy them. And there was one week where the trainer, there was a mix-up and they didn't turn up. And between them as a group, they decided that actually we know what we're doing a bit here. None of us will blame each other if an accident happens, and we'll just crack on. And they led that session themselves, and they could have just sat there drinking tea or spent the afternoon doing something else. So I think that we made a difference in terms of their recognizing that exercise can be worthwhile and enjoyable. 13 of them said that they'd like to have a follow-up class at the leisure centre, and we really tried hard to make that work, and unfortunately they couldn't get the right trainer with the right qualifications excuse me, to be able to do that. So yes, it was one of those situations where we just didn't quite get that bit right in how we went forward. And 4 of them were still saying that we're doing those exercise snacks at home and using the exercises. So the things that we did, they had options for how they would exercise. And this is some of the quotes from those interviews that I did. So I'll just quickly pick up some important themes from there. And I'm sure you can read quicker than I can probably talk. So one lady had gone from being completely sedentary to doing at least hours of hill walking every single day. She was doing a formalized class as well. And she was just more aware of what she needed to do. We had others that were going together, and so they kept that friendship group, and they were doing Zumba together, which was fabulous. And other people who'd explored a little bit about why they come to the group in the first place. So they'd just not found themselves where they expected to be in that retirement phase, but they'd never really enjoyed exercise before, but they were going for it, and they were no longer frightened of exercising, and they were again active and doing lots of formalized class groups each week. The theme that came through is that they would have liked that follow-on session. So I think people were willing to pay for it too. They didn't expect us to spoon feed them and to hold their hands and then for us to continue that. They were quite happy, that this was meaningful to them, and they were happy to spend their money on it. And again, that those musculoskeletal problems had improved, which is great. And although we really didn't have time to sort of really look at HbA1cs or any of those truly objective health markers that we would look at, and if I ever get the opportunity to run this in a longer study, that I'm going to be trying to pull that data in to improve its efficacy. Yeah, one patient donated that actually his HbA1c was in a much better place for the changes he put in place in that 3 to 6 months since we spent that time together working. And again, just a very similar sort of idea here, really. But someone that also had reported their blood pressure had dropped. But that social isolation bit may be coming through, that they wish that they didn't have to do it by themselves. So again, if we ever get the opportunity to do this again, we'll be looking at how we encourage that friendship and keep things going. And it's always hard, isn't it, when you put a group of people together who maybe don't know each other, maybe from different backgrounds. As I said, my population is hugely different. And these people were, were not picked by their postcodes. They were just picked by motivation to want to be there. And you can't always guarantee you're going to get somebody in the right place. But we only had 3 people drop out. One of those just because it really wasn't the right thing for them. The group exercise wasn't their bag. And 2 dropped out because they found it too hard. And actually, if we've been honest with ourselves at the beginning, we'd pick them on the group and put them in because they were so motivated. But they both have very high BMIs, and I think probably we weren't the right setting for them. But we made sure that they were supported by Joe. He spent some time with them afterwards. He followed them up, and we got them into the exercise programs, aim more at weight loss so that they could take that journey forward and keep that motivation without us and destroying that motivation for them by feeling that they've failed. So what did it teach us? So short, intensive exercise and education intervention can bring meaningful benefit to individuals. It's hard to generalize. This wasn't a research trial, but those individuals that took part felt it would be beneficial. That the specific nutrition information for older people perhaps isn't out there. When we were in our sessions, there seem to be new themes that they weren't aware of before around protein or bone health and all those things that actually are really crucial. And actually, when you think about it, we don't think about getting that message out unless we see them in a chronic illness appointment at all. So it's one of those things where so yeah, it's getting that message out there. Hand holding is really important. These people all wanted to do something positive, but actually us just sending a text message saying there's a local class, get yourself down there, they're not going to do that. It's a frightening prospect. And certainly when we think about gyms and exercise classes, we all have an idea of these people who are much fitter than us, probably much thinner than us, they're all in their lycra, and that's an intimidating thing. So there was a lot of hand holding that went on here to get them through the door, but actually they were able to continue for the most part without us doing so. But that plan for continuation is even more important than getting them through the door in the first place. And that's the bit that if I get the chance to roll this on a different scale again, that's the bit that we will concentrate on. But having spoken with the local leisure centres, even just in the last couple of weeks, they are actually looking at doing something off their own back with this, and again having that continuation. So hopefully for the local patients that will happen. And yes, so there was enough a positive trend to feel that this is a meaningful thing and we should really keep pushing for it. And I won't get off my soapbox. I shall keep shouting it loud. And I know in Nottinghamshire, when they looked at the Frailty plan, the poster that I made as part of my presentation at the end of this project actually was on the reference list. So I know that there are people that are motivated and would like to see this come forward locally. It's just the money, isn't it? And how can you put this forward above things where patients are, suffering here and now? So hopefully it's a future to come. And although our programme might not be right for everybody, it was right for most people. So it's a formula that's worth taking forward with a few minor tweaks. And my personal message going forward is that actually lifestyle intervention, when delivered sort of human to human, and I think that's important, this needs to be people in a room together, not a doctor and a patient. This needs to be person to person, supporting and empowering each other can achieve more than traditional medicine and those one-off health chats that we have where we lecture people. And I personally need to get that message out there, which is what I'm trying to do with my spin-off project, which is the Later Life GP on social media and my website, and talking to people and providing education. So hopefully, I think I've run over time. I'm really sorry. But yeah, I have seen a few things popping up in the chat. I'll open the chat now and have a little look and see how it's how we can go. But yes, this is a slide that just reminds me why this is important and why we have to get that right. So that the clean, healthy living that people are doing is actually preparing them properly and yeah, allowing them to live that healthier life. So
kindly agreed to stay on and just answer some of the questions for you. So the first question was around, is there a technical definition of pre-frailty? And some people in the chat did put some responses to that around, you know, a Rockwood scale of 3 to 4 would constitute pre-frailty, and somebody else put another link on there. Would that be your assessment? That's, yeah.
Absolutely. Yeah, I think that the reason we targeted it at that point is because I didn't consider these people to be frail, even though for our patients under EFI, they had kicked the boxes to be suggested that there was frailty. We're just at that point of vulnerability. We're just on that shift point between feeling well and being well, and actually things getting worse. So absolutely, I think that's pre-frailty is where we're targeting to be truly preventative.
Yeah, that's really helpful. And were people given an individualized nutrition plan alongside their exercise program? That was a question. And also, was healthy weight gain also measured?
Yeah. So well, in terms of weight gain versus not weight gain, we just took a pre and post that 6 week sort of measurement. So we didn't really think about the underweight people and where they came from as a metric that we looked at. And we didn't give out individualized care plans and nutrition plans for each of these people contributing to. The nutrition talk came at week 2, so right at the beginning. But there was that opportunity to learn more from the dietitian, and anyone that had a worry or something they wanted to address on a one-to-one basis was given that opportunity to have an appointment specifically with Lisa, and then work out what they needed to do on an individualized basis, which actually was quite a nice way of doing it, because it also meant that they weren't discussing all of those personal things in that group setting too. So not as standard, but there was the option too, I guess, is the answer to the question.
Yeah, and I think that's really helpful, because I think what really came out through this was that sort of sense of that you met people where they were at in their journey, and that there was that sort of balance between a generic something generic, but something actually that met them individually, which really came out quite loudly, which was great. And I think that sort of links on to the next question, which is that, somebody's made a comment, I love that people self-organise for a class. I'd be really interested in how we can promote this kind of self-organising and not having to rely on an expert to lead it. And I think that probably keys into that initial phase of really targeting what people wanted. But I wonder if you feel there's anything else you want to say about that sort of self-organising aspect of it.
Yeah, so I think that it's a daunting thing exercising if you've never exercised before, and particularly perhaps if you're an older person and you feel that leisure centres or gyms are the domain of young, fit, skinny people and wearing lycra. But actually, so getting sort of over that threshold and that hand holding is important. But I don't think it needs to be a doctor that does it, and I think it needs to be someone who is respected within the community potentially. So whether that be people from the leisure service, whether that be someone linked directly with health, whether that be someone coming from the integrated networks that are taking off soon, and whether actually that's a great format for this to go forward through, from a more community base rather than a medical one. And I think maybe as this moves forward, it's that opportunity, if someone's been through that scheme themselves, they've loved it, they felt it's really beneficial, do we get those people volunteering to try and lead it, to try and move things forward within the neighbourhood teams, and bringing that forward, that real motivation, and potentially more time as well, if we are in a bracket where some of these people are, retired, and so they have the time and the motivation to do it. But yeah, and then it's the spin-offs that go from there, isn't it? It's putting people together, it's building that community within their little groups, and allowing them to take their own spin-offs and have the confidence to do so.
Yeah, and I think that's a really important point, isn't it? I was very struck by the comment that they made, that they weren't going to blame each other if something happened. You know, that kind of sense that they'd stepped away from the risk management sort of approach to it, and actually were just saying, we're just humans in a room exercising together. There was a real sense of ownership in that, and I love that idea of them taking it forward to sort of pay back to other people, and there's a level at which that's empowering for them as human beings, as well as in terms of the actual exercise, isn't there? There's an empowerment element of that emotionally.
And we need purpose in life, don't we? And the moment we lose our purpose, we get lost. And actually, you've retired, you've lost maybe where you were as part of that identity, life's changing, friendship groups are changing. And actually, if we can do something that plants that seed of purpose again and brings that, that next step forward, well, wow, that's something meaningful, not just for the individual, but for the community as well, isn't it? It's about that empowerment, really. And just, everyone knowing their worth and what they can bring to the table.
Yeah, absolutely. There's another question here about did you record medication reduction as a result, e.g. fewer antihypertensives or antidepressants? And obviously medication is 60% of the general practice carbon footprint, and alongside that the metabolites going into the water and harming our rivers and so on. I mean, I guess it was quite a short project to get that data, but I imagine that might be a future sort of area of investigation, mightn't it?
Absolutely. And I think, 6 weeks wasn't enough to be convincingly changing things. I mean, we didn't get to the place where we could say, actually, this person's blood pressure has dropped and therefore we can lose a medicine. But certainly the patients that had lots of medicines on their list, they were given the opportunity to speak with our clinical pharmacist and to sort of explore that polypharmacy side of things. And certainly when I've been talking with the local leisure service with Carlton Falterham, the place where we ran this scheme from, about how they go forward with this next phase with them leading it rather than health. One of the key things that I flagged up with them is that actually we've all got a role in polypharmacy, and actually they're probably seeing these patients more frequently than we are. And if they're taking someone through a scheme and they're noticing that maybe they're losing weight, or maybe their glucose meter's beeping a lot in the sessions and they're faffing around with jelly babies or whatever else, or if they're getting patients that are reporting dizziness and things as they're moving forward, actually it's sharing that responsibility, isn't it? And actually I strongly encourage them to say, maybe you need to go and speak with your GP or the nurse or whoever else and just look, do you need all of these now? Has something changed? So I think that absolutely reducing polypharmacy is part of my job. But I think that's a really important thing, and sharing that responsibility and getting that idea out there too, that we all have that responsibility.
Yes. And I think what really struck me about this project is that you had taken quite a holistic approach, and you had the support networks around the project to make sure that those unmet needs were picked up on around this project. And that feels very important, because it's so easy to have things in isolation, isn't it, without dealing with the holistic issue around some of these things that are highlighted when you start doing a project like this. Somebody else has commented, would you be willing to share your poster?
Yes, I can do. It was an early the early data, essentially, so from just a few weeks in, really, so that the data is slightly different to the end collection, but absolutely I'm very happy to share that, so I can send that across to you and you can distribute as well.
That's wonderful, thank you. And then there's a question that you mentioned about integrated neighbourhood working. How do you think that might work? I mean, I guess the question is in relation to this project, what that might look like.
So I'm hoping that this is in a place where it almost could be picked up and taken forward. And we do have a SOP in Nottinghamshire that's been formally produced. That so if someone wanted to take that forward, they could. But I think that the integrated neighbourhood teams is exactly the place that this needs to be. This doesn't need to be run by a doctor. A lot of it is common sense, even from the medical part of it, if that may. And people can be signposted, can't they, to touch back base again. So yeah, I'm a salary GP, so I don't have quite that influence over how we're building our local teams. But yeah, the guys that are doing that locally within my area are aware of this project. And so hopefully, that is something that can be that next step, bringing in the voluntary sector, bringing in leisure centres, all of those things together that remove it from the medical sort of pocket as that it's been sat in before, allow us to do the bits that only we can do, and actually take this idea forward so that it's run by and hosted within the community.
Yeah, that sounds amazing. I'm going to use chair's privilege to just ask you a question about whether there was any. Did you have a sense? I mean, I know you said you didn't sort of select the postcode or anything, but I'm just wondering if you had any data about whether this was appealing to the sort of to the worried well, or that it was actually potentially increasing health inequalities, or whether this stretched across the social spectrum in a sense, in terms of how you recruit your patients.
Well, we didn't specifically look at that, but certainly the people in the room were from different professional backgrounds and non-professional backgrounds. And I sort of expected, because I've been in this job since for 11 years now, so a long time, and I was well known locally, and I sort of expected that maybe it might be my patients that followed and came and joined in, and actually that wasn't the case at all. And even patients that there was a nice split between the different practices within the PCN. It wasn't just our patients that maybe recognized my name even if they didn't know me. So I think that yes, perhaps, you know, that this was maybe going out to people who were quite proactive in their nature, and there may have been people that we missed because they didn't feel they could be brave and put themselves forward. But we did have much more of a mix, and not necessarily the cohort of patients that I expected.
Well, that's really fantastic. Thank you so much for that. I'm just going to share, because I don't know whether because our slides didn't share earlier, I'm just going to share a little bit about the Greener Practice platform. And as we were just saying, the lovely thing about this project is it really does satisfy all the sort of principles of sustainable healthcare, which is patient empowerment, disease prevention is the first one, and health promotion and health creation in this case. Patient empowerment at all levels. It's a lean pathway, you know, it's much less carbon costly than referring people to frailty programs in the hospital and so on. And it's also a low carbon alternative to all the other programs certainly to things like medication and so on. So it sort of fulfills that brief in all directions, really. But I'm just going to see if I can share my slides, if it works this time, and if I don't encounter techie difficulties. Let's see if I can get it to share. Okay. Right. Sharing?
Yep.
Okay.
Yes,
brilliant.
I can see it.
Back to the beginning now, and I can't work out how to do that because it's oh, let me stop sharing. I'll just go back to the beginning of the slide deck because it's not oh, how do I do that? Oh, there we go. Okay. Oh dear, it's being very slow. Right, okay, let's try that again, and hopefully it will. Okay. Right, is that working? Oh, now I've got a black screen.
I can see a bit at the bottom though. Yeah.
Oh, all I can see is a black screen now. Oh, wait.
I can see it.
There you go.
Yes, got it. Okay. So just going to talk a little bit about the Greener Practice platform, which is a paid platform. It's a very modest amount of money to join Network Plus to get access to over 50 quality improvement projects and about 200 resources that support planetary health practice. And I want to focus on the ones that relate directly to Anna's project really today. Ones around frailty, either prevention or dealing with supporting patients living in frailty. So one of the things I want to just highlight is some planetary health cases written by Dr. Mike Thompson, who's a very prominent member of Greener Practice, who's written a planetary health case, which is for sort of educational purposes for trainees and so on. And actually just really illustrates the issues around why this is a planetary health issue as well as a public health issue. So this is a case of repeated hospital admissions for a patient who's frail and living in a care home. And it highlights the need for advanced care planning, deprescribing focused structured medication review, and a dignity focused approach to end of life care. So I would encourage people to consider using that for trainees, and also just to highlight the issues for yourselves because it is such a good illustration. There are 3 projects directly related to frailty on the website. One around frailty prevention, which is around setting up a walking group either for patients or for staff, or it might be for both, very productively. And there are two that are addressing prescribing in patients living with frailty. And I know I've mentioned these projects before because these are two of my favourite projects on the website. One is on a deprescribing focused structured medication review for patients, particularly those living with frailty, or that could be for anybody, but this is particularly useful for people who've reached the stage in their lives where perhaps some of that medication is no longer really appropriate. It's served its purpose and it's time to let it go. And then there's another one called Show Me Your Meds Please, which was created originally by a complex care GP in Somerset called Deb Gompertz, who basically led a project where professionals were going into a patient's home and asking if they could look in the cupboards to see what medications people were storing. And again, like Anna's project, this is a really holistic project around recognising unmet need like loneliness, depression, loss of memory and so on, and addressing those needs alongside addressing the fact that people weren't taking their medication. It was around the why of why patients weren't taking it. So a really holistic project. So just going into a little bit more detail, setting up a working group for patients and staff, huge benefits for the patients, also benefits for the practice in terms of improving physical activity for the staff, increased sense of community, savings in terms of the patients, being more physically active, as Anna's highlighted, and healthier patients and staff results in lower healthcare, which has a benefit to the planet. And we know about the benefits. This is a Public Health England infographic about the benefits of physical activity. And there's a case study on there. So basically, it gives you all the tools you need to set up a working group in your practice. And it tells us a little bit about what happened when people did this. So a deprescribing focused structured medication review. This is a sort of 3 to 6 months project overall, although it doesn't necessarily take all that time. It's just that to see the benefits of it, you might want to go forward 3 to 6 months. But huge benefits for patients: improved quality of life, reduced adverse drug reactions, reductions in non-adherence, benefits to the practice because you're just prescribing less, and reductions of 2.7 to 9.9% in prescriptions, financial savings, and obviously benefits for the practice because of all the benefits of not prescribing things that are having an environmental impact. And again, there's a step-by-step sort of guide how to do that, and case studies around what was saved in Liverpool, a massive, probably 55,000 if it was across the whole 10% the PCN. And at the end of doing a project, you get a certificate to say that you've completed that project. So the final one that I'm going to talk about is Show Me Your Meds Please. So this was an infographic that Deb created to explain the project, which is centred around person-centred care. It involved pharmacists, it looked at social care needs, it identified cognitive decline, and there were massive patient benefits. And this was just the pilot in 40 patients, saving about £10,000, £3,000 from saved by a year from deprescribing, and £10,000 in waste, and a huge environmental impact as well. So Network Plus membership is £30 a year for individuals, and from £100 a year for your practice to join, if you have a practice of fewer than 10,000 patients, and it goes up proportionately with that to get 5 places. There we go in at the table. So so that was just a little whistle-stop tour about the platform. So and I'm going to stop sharing now. Oh, how do I get out? Yeah, there we go. So all that remains is to say a huge thank you to Anna for the project. I really want to be able to do a handstand like that at the end of my 6 weeks of exercise, but I think that might be a stretch too far. But I definitely feel I'll be much fitter approaching my 70s, because I'm now in my early 60s, so I haven't got that long to go before I reach the sort of 65 threshold. So start to be inspired by you. Thank you so much for your time.
Thank you for having me.
Thank you.